Dr. Perry. And thank you all for being here. I know it's getting really close to lunch, and it's hard to follow up a genetics talk for a genetic epilepsy with a surgical talk. So I'm sure a lot of you are wondering, why are we even talking about this? And truth be told, when I got asked to speak about epilepsy surgery and Dravet syndrome, I thought initially this is going to be a really short talk. We're going to dive into it because the reality is we know what we know and we know what we don't know, and we have a lot to learn about how to manage Dravet syndrome right now. And I think it's really rough to follow a genetic epilepsy talk when you see how much has changed from 2017 to 2022, and it's exciting to see what we'll see next year, just in that next column in 2023, because we are learning a lot, and a focus on long-term, the future management of Dravet syndrome will be these disease-modifying therapies. But for now, we're going to talk about what our experience has been with epilepsy surgery in Dravet syndrome. So I'm Dave Shahani, and I am primarily a clinical pediatric epileptologist, and I am hoping this will be useful to some of you. So not to repeat a lot of what has been said and what you all know, there is a wide spectrum of phenotypes, and when we think of Dravet syndrome, we tend to really focus on the seizures, but we recognize that there is an impact on seizures, developmental outcomes, both with cognition or motor function, and the general consensus is early recognition improves outcomes, early treatment improves outcomes, avoiding the wrong treatment improves outcomes, and we are very motivated now to diagnose this quickly, get you on the right medications, get you on the right treatment path as quickly as possible. And so what that lends us to is kind of a common approach to how we manage difficult to control epilepsies. We all have a basic conversation about lifestyle changes, focusing on making sure that you're sleeping well, eating well, hydrating well, making sure that we tiptoe around anything that can cause an increase in temperature and avoid hot baths. And it's a dramatic change in how we look at life. And then you meet one of us, drug pushers, who end up saying, hey, start this medicine, start that medicine. And it ends up becoming very overwhelming and frustrating, as many of you have experienced. The consensus statement that I believe you spoke about earlier today with Dr. Worrell that came out in May is really focused on recognizing which medications we start with. And there is a method to our madness based on the evidence and based on what we have seen be helpful. So this is consistently, whether you have Dravet syndrome or whether or not you have another form of epilepsy, consistently the first couple steps. The article that got published in May, the consensus of how we want to diagnose and treat Dravet syndrome, really focuses on utilizing medications at least at the first and second line treatment. Then there is some debate. Usually to your third or fourth medicine, we're going to start having conversations about the risks and benefits of additional medicines and then considering diet therapies. So this conversation is quite complicated, and often as parents it's a little bit of a blind side, because once you've tried 2 medications, you're kind of like, okay, let's try a third one, maybe this will work better. Let's try a fourth one, maybe this will work better. And unfortunately, in the world of epilepsy, we do know that when you have seizures and they are not responding to 2 appropriately chosen medications, the chance that the third medicine, the fourth medicine, is going to make you seizure free starts to decline. And in that situation, we are highly motivated to talk about those next options. And this is where the diet therapies come in, the ketogenic diet, the modified Atkins, low glycemic index, which is cumbersome, challenging, particularly when you're dealing with a number of frustrating factors based on whether or not they're even willing to eat. And whenever diet therapies and medications fail, at some point, there is a conversation about epilepsy surgery. And that is a terrifying and complicated conversation, but it needs to be had, because when you have exhausted different medication options that have a declining benefit going forward, and the chance that this is really going to make a meaningful impact on your life, we have to consider all the options on the table. And notice I put disease-modifying therapy in this kind of funny-looking bubble at the bottom, because that's a game changer. And that's what I know a lot of us here are very excited about and see a completely different path, which may be changing how we have approached epilepsy for years. So when someone does get to the point where they have failed medications, they've tried diet therapies or can't tolerate a diet therapy, we need to figure out if surgery is a candidate, whether you have Dravet syndrome or any other form of epilepsy. And the way we do this is we have a kind of standardized approach called a phase 1 pre-surgical evaluation. We bring you to the hospital, we actually put you on a video EEG, and we take you off your meds. And we make you have seizures, or we watch you having seizures. The purpose of this is to figure out, is the seizure coming from one part of the brain, from multiple parts of the brain, or the whole brain at once? And then we have a number of other tests, MRIs, PET scans, magnetoencephalography, tests that I'm not really going to go into because I want to focus more on what the results generally show. After we do these tests, we're hoping to learn one of two things. Either that your seizures are coming from one part of the brain, one focus, and consistently lining up, consistently concordant with all of these other tests that show this area of the brain is misbehaving, and this is the cause of your seizures. That serves as a potential target to remove the misbehaving part of the brain and potentially stop the seizures and reduce the need for medications going forward. The other thing we learn is that you have generalized seizures, seizures that happen in the whole brain all at once. In that case, there is no single part of the brain that we can remove, but there are some surgical options that could be beneficial if the medications, diet therapies haven't helped. Unfortunately, with Dravet syndrome, it's really important to understand how this epilepsy is impacting the brain and how it changes over time. We kind of hinted at it with Dr. Helbig's talk that late diagnosis can often lead to the inappropriate treatment, the wrong medications, or even in some cases, the wrong surgery. Because early in life, the first year or so, we often see hemiclonic seizures, seizures affecting one side of the body. And if I just see you in a single month or a single 6-month period, and I always see you having seizures on the left side of the body, naturally going to think there's something misbehaving on the right side of the brain, and we are going to chase that with all of our tests. And we can get led down an incorrect path, which leads us to believe that the seizures are coming from one focus. But as Dravet syndrome progresses, as the SCN1A variant changes, we've seen that kids develop, after about 1 year of life, other types of seizures, more generalized seizures. Atypical absence, where they're staying off, or their whole body starts to jerk. They have the generalized myoclonic seizures. And so when we have these generalized seizures, it should put a pause on being aggressive surgically and wanting to better understand what's going on. This is why getting that genetic testing as quickly as possible and understanding your variant changes outcomes and allows us to make sure we don't make mistakes. Over time, we learn that we have a mixture of epilepsy. We have both focal epilepsy and generalized epilepsy. And there's no single portion of the brain that this is coming from. And so it definitely influences our options. So what are our options when we talk about epilepsy surgery? We've got resection, which tends to be the first one that you think of. Someone's going to cut a piece of brain out of my brain and hopefully stop the seizures. We've got laser therapies, when we can find a single area of the brain misbehaving. We've even got hemispherectomies, where we remove half of the brain because all of the seizures are coming from different parts of a single hemisphere. These are considered very permanent surgeries, and we are not finding that this is helpful in Dravet syndrome for a lot of reasons, which we're going to go into. We also have on the top row more palliative surgeries. The Corpus callosotomy, which we're going to talk about a little bit, where we actually separate the two halves or the two hemispheres. We've got the two on the right, top right, which are neuromodulation devices, the vagal nerve stimulator or deep brain stimulation, which is kind of an emerging surgical technique to treat various types of epilepsies. And so the jury's still out on that, but we're going to review what we know. So first, let's talk about resection. Prior to this early diagnosis and easy access to genetic testing, many people were being diagnosed with focal seizures. In fact, some people with Dravet syndrome also have abnormal MRIs, and this is where the confusion can start. Some people can have what's called a focal cortical dysplasia, and I know this picture in the top right isn't a great example, but there is an abnormality in the top left of that brain, in the right frontal area, that shows that a portion of the brain didn't form correctly. We call this a congenital malformation or a focal cortical dysplasia. Now, many people have epilepsy just because of this. There are some patients who have Dravet syndrome and a malformation of the brain. And this is where it gets a little confusing even for your epileptologist, which is why you have to be very judicious and make sure you're understanding where the seizures are coming from and what types of seizures we're having. So there are not a lot of research, not a lot of papers that actually talk about epilepsy surgery, and this is another point that we need to make, and as you've probably seen over the past few talks, you have to be very judicious about where the data is coming from, how biased the data is, and if this truly is a very solid study that we can reliably take this information and say this will be useful to my child or to my patient. Unfortunately, a lot of these are retrospective studies. They are not randomized. They are not trying to figure out if someone is going to do good if we do the surgery or if we don't. This is mostly looking back in time and saying, whoops, we shouldn't have done that. And unfortunately, that is how we've learned a lot, and hopefully how we're not going to make the same mistake twice. There was a study out of Europe where they looked at 6 patients with Dravet syndrome who also, 4 of them had evidence of dysplasias, meaning that there was one area that was misbehaving. They removed that area that was misbehaving that they could see on the MRI, the PET scans, the EEG, and they found that none of the patients who had a pathogenic SCN1A variant and had a clinical diagnosis of Dravet syndrome got better after surgery. So they learned the hard way that doing surgery did not help any of these patients and potentially caused harm from the changes after surgery. There are 2 other studies. This one looked at 6 patients, and they had various malformations. 2 of them underwent surgery and, again, had no change in their seizure frequency. And then what I found interesting, so this paper, and I apologize, I can't say their name, but Bezgalu, in 2020, published on 8 changes. And this is kind of going back to the last talk, where we have SCN1A variants that are sometimes disease-causing. We have variants that may cause less severe disease. We have variants that actually don't cause Dravet syndrome. And it is so important to know that G.C.P. to understand where you fall into this group of patients. Because group 1, 2, and 3 were actually various changes in the SCN1A gene. Group 1, they actually showed people who had suspected Dravet syndrome. And in these patients, whenever we found a focus for their seizures and we went to surgery to remove that area of the brain where the seizures were coming from, their focal seizures actually improved. But they continued to have the generalized seizures that were likely associated with Dravet syndrome. So in some way, there was a benefit. The second group that had true classic Dravet syndrome, that was a clinical diagnosis, 2 of them also had dysplasias. One of them had a scar on their hippocampus. They went through surgery, removed the area that the MRI data, the video EEG data was suggesting is a very active site where the seizures are coming from. And they had no clinical change. So when there's this true classic diagnosis of Dravet syndrome, it suggests that surgery is going to be less than beneficial and probably make no significant difference with the harm from surgery. And then there's this group 3 that has a change in the SCN1A variant, but it's not necessarily one that fits classic Dravet syndrome. And this kid had a single area from the back of his brain that the seizures were coming from. They were able to resect that area, and he was seizure-free. So it's very important to know your single polymorphism, your version, if you will. So in the paper that came out in May, there's a strong consensus that resective surgeries for patients with Dravet syndrome is not going to be beneficial, and we really should not be considering it. I think there are going to be very, very rare alternatives to that statement where we may consider it, but with a very complicated conversation. So if resection and potential cure is not an option, is there any way we can help with surgery? And there is some suggestions to say that palliative surgeries can be beneficial in the right patient, but not frequently. The most common that we see is the corpus callosotomy. This has been around for decades, and it is a surgery where we separate the right and the left hemispheres. There's actually a band of wires that connect the two sides of the brain and allow for information to pass from side to side. From a surgery standpoint, it's actually quite well tolerated. Most patients actually do very well and make a full recovery after this surgery. There may be some temporary weakness, difficulties with speech, something called disconnection syndrome where the right and left brain get confused because they're not talking to each other anymore. But most patients do get better. This surgery, however, is not useful for focal seizures. If you have seizures coming from one part of the brain that are not spreading to the other side, separating the two doesn't make a huge clinical difference. However, this can be really helpful for generalized seizures. And of the different types of seizures, we find that kids who are having these sudden drop seizures, where they suddenly fall and hit the ground, that type of seizure responds extremely well to the corpus callosotomy. And depending on where you read, it's somewhere between 60 and 90%. It also can be helpful for generalized tonic-clonic seizures. However, when this surgery has been performed in patients with Dravet syndrome, and as you can see, we have very limited evidence, as well as a few anecdotal cases, which I have seen myself, corpus callosotomy does not seem to have a dramatic benefit in patients with Dravet syndrome. So 2 kids in the study through Germany actually underwent corpus callosotomy, and both of them did have a reduction of seizure activity by more than 50%. One patient who actually underwent 2/3 of a corpus callosotomy, which is one that we do to minimize the side effects, had no significant change in their seizures. And in my experience, I've seen 2 kids with corpus callosotomies after Dravet syndrome, and it has not had any change in the generalized epilepsy or the focal seizures. So there is still some discussion to be had about the benefit. It really depends on the type of seizure you're having and what we are trying to achieve from surgery. It is a complicated discussion that you have to have with your doctor, and it's something that you have to understand is not going to necessarily cure or control all of the seizures, but can, for the right kids, have some impact. Therefore, right now, the consensus is that there's a consensus that we should not be considering corpus callosotomy, but more evidence is needed. And then there's the vagal nerve stimulator. So this is now in a category of neuromodulation. These are devices that use electricity to change the way electricity spreads through the brain. The vagal nerve stimulator has been in use for since the 90s, and it is a device that's implanted in the chest, and a wire is wrapped around the vagus nerve. The vagus nerve is the largest nerve that has information going to the brain, while most nerves have information leaving the brain. This nerve, by wrapping this wire around and sending electricity through it, can decrease seizure activity. It is not, by any means, a foolproof, effective way of managing seizures, but some people do have benefits. There's kind of 3 ways that this works. We program how often this gives a dose, so it actually kind of acts like a medicine. It also has a heart rate detection for when seizures happen. Some of the seizures will actually cause a rapid increase in the heart rate, and this device can, in theory, detect that change and try to deliver an extra stimulus to try to stop the seizure before any of us can respond to it. And then there's also the ability to swipe a magnet, which we hope will actually stop the seizure faster and avoid the need for rescue medications, reduce the frequency of status epilepticus. So it offers a lot of promising technology, but unfortunately, it's not as great as we hoped it would be. There's not a lot of data out. The biggest review article is a meta-analysis where they looked at 13 studies of 68 people who had the vagal nerve stimulator for several years. They were not able to gather precise improvements in seizures for the majority of patients, but they were able to analyze 28 of those and see that about 50% of them had about a 50% reduction in seizure. There's another study that recently came out from Korea, and they have a little bit more promising results. And I think what's valuable to take home from this one is in the 22 kids they followed for about 2 to 3 years, they placed the vagal nerve stimulator and found that there was increasing benefit with seizure control over time. And they saw that after about 3 years, there was about 63% reduction in seizures. Now, you have to take this with a grain of salt. It's not universally applicable. We do commonly see that the vagal nerve stimulator does have improving efficacy over time. It seems to plateau around somewhere between 3 to 5 years, but we do see that there is some benefit. That being said, there are many people who have the vagal nerve stimulator placed and see no improvement, no significant change. And the consensus that came out this May is that when you place the vagal nerve stimulator in a patient with Dravet syndrome, we can expect about a 50% reduction in seizures. And unfortunately, the evidence does not support that the magnet is that effective at preventing status epilepticus. It does sometimes make the seizure a little bit shorter and stop the seizure, but it is not as effective as we would like it to be. Now, another way of looking at this that I think can be very helpful for parents, but you have to take with a grain of salt, because when we do survey-based studies, there is a bias. It is the people who are on Facebook and responding to the survey. And so you're not really getting the full gamut of experience. You're not getting some of the people that are less than happy with the device or even more happy. So there was this study that actually just posted on Facebook a couple times for parents who had, or caregivers, even adults who had the vagal nerve stimulator and had it for at least 6 years. And of these 49 caregivers that responded, there was about 30% that had reported a 50% reduction in seizures. So it was a little less than what some of the studies have shown. About half of them did feel that it reduced the seizure frequency, but seizures still occurred. 84% actually said there was a reduction in the intensity of seizures, for what that's worth. And 3 out of 4 said they would do it again. So it's a discussion that I think you can have with your epileptologist if medications and diets are not working, but I also say have this discussion with caution and realistic expectations, because it is a useful tool that is not as good as we need it to be. And finally, this is a little bit more of a gray zone, deep brain stimulation. This is where we actually target the thalamus. The thalamus is this region in the brain that's deeper in the middle that actually seems to be very involved in how seizures spread through the brain. And the thalamus has projections or connections to the entire surface of the brain. And what we found over the past decade is that by using deep brain stimulation in certain regions in the thalamus, we can treat many different types of seizures, both focal and generalized, and in some cases, kids who have both, like our kids with Dravet syndrome. That being said, this has not been studied. And it is very much, at this moment, still experimental, not approved for 12 and under, and still has a lot to learn. There was a single case series that I could find, and this too was published almost 10 years ago, and it was on 2 adult patients. There was a 19-year-old who had Dravet syndrome and a 34-year-old who had Dravet syndrome. The 19-year-old had it placed in the anterior nucleus, the front part of the thalamus, and reportedly over, if I can remember correctly, I think it was over 3 years, had an 80% reduction in seizures. Another one, the 34-year-old, had the centromedian nucleus targeted did not have any change from deep brain stimulation. They even moved it to the same place, the anterior nucleus, 2 years later, and still did not have a significant change in seizure frequency. I think we could have a lot of theories as to why this might be. I mean, these two individuals are much older, and we like to catch this disease a lot sooner and intervene much earlier. So maybe there is some role in the fact that they've had epilepsy and seizures for decades, and it has already caused some injury. Maybe this is just not the right technique to pursue. But I think the jury's still out, and we do need to explore this further, especially in our kids who are not responding to any of our therapies. So the short of it, be careful when you talk about epilepsy surgery. It is generally not recommended for patients with Dravet syndrome, except in certain situations. We always consistently recommend medications, diet therapies, and undoubtedly, as we learn more about these disease-modifying therapies, we're going to be pushing that as well. There is strong evidence to say avoid any surgeon or anybody who is telling you we need to do a resection and remove one portion of your brain, so don't let anybody do that unless there is a very clear reason to do so. There are rare instances where the corpus callosotomy, separation of the two halves of the brain, could be beneficial, and there is some potential benefit from neuromodulation when you've exhausted your other options. So it is still on the table and needs to be explored more. So thoughts, questions? Yeah. Yeah.
Thanks, Dave. That was a tough topic that I gave you, and I knew it was going to be a tough topic. And as the person who loves epilepsy surgery and loves Dravet, I knew you'd be good at doing it. So all right, questions.
Let's see what the jury says.
Yes. So it's kind of a comment and a question on the DBS part that you did mention. So because I was not really aware of that case report. You mentioned this was like 10 years ago, and I wonder if the advances in imaging-based targeting could play a role in like hopefully getting better outcomes in those patients. Of course, this is an N of 1. So there was this recent study from a randomized controlled study from Australia that was published in Annals of Neurology, and they had showed that actually CM-DBS was beneficial for, unfortunately, for subclinical seizures on ambulatory EEG recording, and that was for the LGS population. And then there was a subsequent paper from the same group, and they looked at actually connectomics analysis, and they found that actually targeting the more lateral part of the CM, so parvocellular CM, which does also maybe get some VL coverage, they found that that can be associated with the best outcome. Of course, maybe more studies are needed to look into that. So I just wonder how that may help. And also, this is a different population where you could get both focal and generalized seizures, various networks. So maybe 4-lead DBS, which has been done at a few centers, including like our center in a few cases. Still, there are some limitations to that technology in terms of 4-lead DBS. Currently, the only devices that can be used would be the Intellis, Medtronic, or the Boston Scientific one. So I just wonder, what are your thoughts about that part?
I think it's a great question, and in the world of pediatric neurology, you have to be an eternal optimist. You have to constantly be willing to look and push the boundaries. So I think the jury's still out. We are definitely excited and exploring this because there are a number of kids who have multifocal or generalized epilepsies, whether it's Lennox-Gastaut syndrome or Dravet syndrome or many, many other causes that we're learning about, that need to consider these options when medications and diets don't work. And I think there is a lot of excitement about whether or not to target the lateral aspects of the thalamus, the centromedian, the internucleus, or even the posterior aspect, depending on where the seizures are coming from. I think the jury's still out. I think it's very important to recognize that these studies are trying to make a generalized statement on whether or not a surgical intervention can be universally applied to different causes of epilepsy. And understanding that deep brain stimulation, while is it a therapy, And it does seem to be very useful in generalized epilepsy or in patients who have these multifocal malformations. It's yet to be seen how it's going to impact genetic epilepsies that have a somewhat progressive disease pattern. So I'm excited just as much as you are, and we are also exploring it at Cook Children's, and but we're still optimistically cautious.
I actually had a question about the medicines,
Yeah.
because I've seen that funnel a couple of times now, and to qualify, my daughter's 22, so she's a little older. But historically, it was always, we always had a recommendation of a combination of those medicines. It was never just one. So has that changed over time, and is it now when you treat a new patient, do you treat it singularly with the medication, or do you try what I would call a combination of the medications available?
That's an excellent question, and I think you're going to get a different response from every clinician. There's no data to really guide whether or not a larger number of combination at lower dosages or a high dose of one or two medicines is more effective. Most of us are working with a combination of medicines, and mostly because the reasoning is you have a seizure, you get started on a medicine, but you are still having seizures. And there is this anxiety about taking away a medication before adding a new one. So we are constantly additive and removing and additive. So I don't think that has changed. I think it's more the decision-making on which medicine to choose. That knowledge base is growing. And so I think we're learning definitely to avoid sodium channel drugs, and we're learning which drugs tend to be less effective but commonly used as first line. So this sort of is trying to push the envelope that when you have that genetic diagnosis, go straight to the medicines that we know are more likely to be effective so that you can work through this process of medications, diets, and other interventions as quickly and as effectively as possible.
And I would say, while not impossible, it's still exceptional to have a person with Dravet on a single drug. There are examples, it certainly does happen, but oftentimes there's multiple seizure types, right? And so many of these drugs that are newly approved for Dravet syndrome are very good at convulsive seizures, tonic-clonic seizures, focal impaired awareness seizures, but absence and myoclonic seizures do not tend to respond nearly as well. And so they often, at least for that, would need another medication that might be good for that seizure type. So. And just so you know, we're going to start a little bit late after lunch, so everyone will have time to eat. We're going to start at 1:15 instead of 1.
Okay, I just had a question, because I was curious about this exact same thing. Does Keppra count as one of the first lines or not? Because my daughter started out with that, and now we're on second and third line, but I mean, nothing's changed with the Keppra.
We all tend to start with Keppra across the world, especially before we have the diagnosis, which tends to be the case, that we see children with seizures and then we send the genetic testing results, but while we're waiting for the results, we start on Keppra. It's mostly a decision by side effect profile, but unfortunately is not particularly helpful at... Yes, ma'am. Yes, ma'am. And I'll leave that, Dr. Perry, answer that another way.
Well, no, you answered it right. I mean, Keppra, there's two ways to think about first line. Is it first line because it got put on you first? Yes, all the time. Happens all the time. If we knew you had Dravet syndrome, would we put you on that? No, we would not. There would be something else we would pick. Doesn't mean it doesn't work, but we think these others would be better choices.
Thanks for the talk. So at our institution, we're sort of running a trial looking at generalized epilepsies and RNS targeting the central median nucleus of the thalamus. Is there any experience anecdotally or trials that are underway looking at RNS and targeting CM nucleus?
None that I'm aware of that are randomized controlled trials. I imagine we're going to see a handful of case series, and I think we're exploring RNS more than DBS at the moment as well. But we're... Even in ours, we had a debate about this on Tuesday of whether or not we were going to go through DBS or RNS for our deep brain stimulation. So I'm not aware of any trials at the moment, but they need to happen.
We could have a contest later and have people vote on which side they think I'm on and which side they think you're on of that debate.
Thanks for the talk. My question was also about RNS. So I was just curious for your point of view on it. I know there's not a lot of data out there, particularly in Dravet, but just curious.
I'm excited about it, but I'm also one person's opinion, so take that with a massive grain of salt.
Okay. All right. Thanks, guys. It's been a great first half of the day.